We'll go ahead and get started. Welcome to our second session of the Best Practices Summit virtual edition for Family Services. And we're so delighted to have you guys here today. I know many of you are probably busy coming back from the holiday weekend and maybe even dealing with donor family cases. So we appreciate that you've made the time to be on. We are recording this today and we'll be happy to share it with everybody, whether they were able to be here today or not. And we'll have our breakout session in about a half hour where you can talk to some of your peers about what's going on in your world. And we're really excited to talk a little bit about, what we're all seeing and experiencing. But I'll just say, from our point of view at RPG, and if you don't know me, by the way, I'm Sean Jordan. I'm the president of the Research and Planning Group in St. Louis. We do a lot of surveys for OPOs, and we've done surveys for many of the folks that are here. And from one of the things that we've really been seeing lately is the difficulty in working in the hospitals with the clinical staff and also with just the folks that are adjacent to the process. And a lot of the difficulty is being created by a very, very challenging hospital environment. And this is something that I know you all are dealing with on a daily basis, so I'm not telling you anything that you don't know. But what we're seeing in the survey data a lot is that there is an increasing need, probably more than I've ever seen in the time I've worked with the OPO industry, to really let people know how much they matter and how much you appreciate whatever role they're playing in the process of helping you to talk to the donor families or helping you to work with any of the donation cases that are going on. And whether that is your own teammates in adjacent roles like hospital development or aftercare, whether that is your own clinical teams, whether that is the folks you're working with in the hospitals who want to be a part of those encounters with the donor families, taking time to just say thank you and letting them know how they're appreciated is so valuable right now. And guys, I'm an assistant Cub or Scoutmaster in the scouting organization. I used to be a Cub Master in Cub Scouts. And I always tell my scouts whenever I'm out with them, guys, you can never say thank you often enough or loudly enough. And I think those are words that I would pass on to you as well, is that if you have the opportunity to thank people for the good work that they're doing and helping you with cases, please make an effort to do that, because it is just a thankless world right now and everybody needs to be lifted. And the mission and the purpose of donation is so important and so valuable, but so is letting people know how they played a role in that mission, and just even thanking them for what they did makes a huge difference. And I can say that with authority because I have seen it in the research data when we're talking to the hospital partners, and I can see it with the donor families as well. When you treat them with respect and empathy, as I know you all strive so hard to do, it really, really resonates with them. And they come back and talk about what an exciting and awesome experience they had because of the great work that you all do. So with that said, now that I have kind of gotten us kicked off, I'm going to turn things over to my colleague, Jenny Oliver. And Jenny is going to give a couple of thoughts, and then she's going to introduce our speaker for today. I want to mention, by the way, if you have any questions that come up during our talk, go ahead and put them in the chat. That makes it easier than having to have everybody unmute. And then we will be sure to answer them as quickly as we can. And when we're done with our presentation, again, we'll be moving into our breakout session, and we hope you can stick around for that as well. All right, thanks. Take it from here, Jenny.
Okay, thanks, Sean, and welcome everyone, and thanks for making the time today, post-holiday. I wanted to I'm really excited about our speaker, and I think she really fits the bill of what Sean was talking about, that there are such difficult times out in healthcare right now. The OPOs are facing challenges, and so are families. So it really does make for some difficult times. So the more you can hone your skills, sharpen your skills, and really become an expert in what you do and become more well-rounded, I think the more successful you're going to be. So that leads me into talking about our presenter today, who I am thrilled. And there's a colleague who can't be on here, and she said to me, I'm so bummed I'm going to miss it. Amy is who I want to be when I grow up in my donation job. So I thought that was great. I know she's smiling and laughing. I met Amy, and this talks about using your network. I had a fellow who was now an attending that came to Cleveland, and he said, I had a great experience. I worked with CORE. I worked with this great person named Amy at UPMC Presby. He said, so I hope we can have that kind of relationship. And Dr. Niehaus was right. I picked up the phone. I called Amy. We had a great talk, talked about him, talked about some of the best practices, and that began our relationship over 4 years ago. But her name has been around in the OPO world because she is that really unique blend. She is clinical, but she works with families and she works with hospitals. Amy ran the UPMC Presby in-house coordinator for a hospital that was a 900-bed academic medical center and a level 1 trauma center. And she, like I said, is very adept at working with families, hospitals, but she's also very effective in understanding the clinical setting, how hospitals speak, how they operate, how they communicate. And with that, she's able to take it and translate it to the families, which is what she's going to talk about today. And I think the most important thing is when I talked about your skills, and again, when I think of Amy, there's somebody who's very emotionally intelligent, reads the room, the entire room, is a critical thinker, and is very creative in her thinking. You have to think quickly on your feet when you're in these situations. And in learning from her and speaking, she's a great storyteller. So I'm very excited today. So she's going to share some wisdom with us. And so I'm going to turn it over to Amy. She's got great stories to tell, and we're going to learn something today. So thanks for joining us, Amy.
My pleasure. Thank you so much for having me, and Jenny for that introduction. I was going to give you a little bit of heck because you found a nice way of saying I was old, been around forever, and then you said all these other nice things. So I guess I think maybe you're the real professional here, and it shows. It's a great pleasure to be back with our friends from RPG. I have been in the field since 2007. A graduate of the Toledo Human Donation Science program, but my background is in rhetoric and communications, as it turns out. So people will tell you that I have a BA and BS, and I will tell you that I write fancy emails. And yet all of these things have come together to really create something special in a clinical setting. For a very long time, I thought I was going to be a neurosurgeon, and I'm delighted to be with a better work-life balance, working alongside neurosurgeons. So I think, Sean, the slides disappeared, but I can talk to them a little bit because when we think about a family approach, I think about it as
You can go ahead and share
curating.
them, Amy, by the way. I'm
You
sorry.
want me to
You
share?
can share them on
Okay.
your side. Yeah, I'm sorry.
Okay, no problem. I can absolutely do that. Let me get back to here and we will go away. Perfect. Thank you so much. Let me look, guys. This is crazy. It's post-pandemic and we still don't have this figured out. And I say we, but it's me. So let's do this. So yeah, so when I think about family approach, I think about it in the setting of curating a family approach, much the same way that a museum director might curate a show or a display. It's about taking stock of what is the story that you want to tell, what resources, images, paintings, sculptures, first person artifacts, secondary things, what is available to you, what can you then have and obtain access to and then put together. And really the approach is that story. And at CORE, we use the feedback that we get from our partners at RPG to think loudly, to think often, to really think about what are we hearing from our hospital partners in terms of how they want to be communicated from the OPO, because the work that we're doing to curate these conversations is happening in a very strange place. And many of us know from choosing to do this work that ICUs are indeed strange places. And we have to be cognizant of the fact that an ICU setting generates stress. There's a 2005 study that showed 33% of family members who had someone in the ICU experienced symptoms of a post-traumatic stress disorder within the first 90 days following that ICU stay. We know, and it's well documented in the literature, that death complicates grief, that those who have lost a loved one in the ICU, more than half of them demonstrate symptoms of complex grief within the first year of that. And we also know, maybe all too well, that communication is not always great in the ICU. This is an environment of a lot of competing demands and a lot of variable skill sets and attributes. It's telling that over half of family members, this is in a 2015 study, reported very low satisfaction with their communication regarding prognosis. And this has a direct effect on the work that we do when it comes time to approach, because we're left holding the bag on the back end of a lot of these unique variables. And then secondarily, as many of you know who've been in the field, you may have had this first person experience that the injury conflict, the complex with which the patient presents, does indeed affect both processing in terms of how families move through their grief, interact with the hospital team, and it's also highly associated with ideas and societal norms of shame, that there's an idea of someone who dies of suicide versus someone who was hit by a drunk driver, and the element of human design is what it's called in the research, that when it is an intentional, or well, you know, that's what happens when you drive drunk, exaggerates the grief response. And if you look even just 3 boxes to the left, we know that these patient populations are already predisposed to have a high grief reaction from an ICU setting and an ICU experience. We know that when our bodies are in grief, we're not processing properly, that we can have a threat response, be in a heightened state of fight or flight, that we're not sifting through and thinking through things in a normal setting the way that you and I are in this moment. And so before the approach even comes to pass, there are a lot of key tipping points, and Sean had alluded to this, the ICU setting in and of itself, the delivery of that bad news, and we'll talk a little bit about that because we know there's also variable performance and how well that's conducted. We know that there are ways that we can improve the authorization potential in that setting, as well as how brain death is communicated to families. And, you know, of course, the actual approach and some of these social and emotional considerations. Was the person in the home when the gun went off? Did they find the person hanging in the garage? Did they open the garage door to see the car running? So being attuned to those things as we ourselves enter into the approach is important. Most of these things are things that we personally cannot control as OPO professionals. And so we're going to focus on how we can use tools in our actual approach that can offset, mitigate, account, and then in areas where there have been really good episodes of communication or engagement, enhance those. So how do we do this? Well, in crisis, what we really want to is lead with emotion, because that's the loudest thing in the room anyway. So we really want to prioritize our empathy. And part of this is being authentic with yourself and who you are as you enter that conversation. At CORE, one of the things that we've done is take a look at our approaches. So after each approach, we have an approach interview by a member of our performance improvement team. They're engineers, they're actually engineers, and they sit down and they talk with the clinicians, and they say things like, how much sleep did you have? How many families have you talked to before you talked to this family? How long were you awake before you talked to this family? What was your state of mind when you talked to this family? We had a coordinator respond, hungry. That was my state of mind. I was hungry. And you can guess, it would probably not surprise you to learn that that conversation ended in a refusal for donation. So we have to be authentic with who we are so that we can engage and prioritize empathy and care for the people across the table with us. We really want to prioritize using plain language and decoding a lot of our medical vernacular to things that make sense. So instead of saying things like ICP or intracranial pressure, using there's a lot of pressure on the brain, and telling and packaging that information in a chunk and in a digestible chunk. I'll often say this is like going to the all-you-can-eat buffet with a teacup saucer, and everybody's wanting to scoop something on your plate. The plate will only hold so much. So breaking down those stories into, this is what has happened, here is where we are now, and here's where we're going. That might sound like, your loved one has had a really severe injury, and right now we're really worried about the blood pressure. We're going to fix the blood pressure, and then we'll worry about what's going to happen next. It's also important in crisis to validate listener understanding. We'll talk a little bit about some of the tools that I've had success in using over the years in doing that for listeners. So, what does this look like in a setting? Hopefully, when you leave in the next couple minutes here, we'll wrap up in the next 12-ish minutes. You'll have some of these tools added to your toolbox. It is incredibly important, as with anything, how things start sets the tone for the rest of the conversation. And so having a steady introduction and opening with a family is an essential part of setting the tone as that professional in the room, the person who can be trusted. When I lived and worked in Houston, Texas, down at Life Gift, I did sleep through a hurricane. I did not hear a thing. I woke up the next morning like, oh, wasn't there like a storm or something, babe? He's like, it was like being in a dishwasher, Aim. What are you talking about? Even if you roused me from that slumber, I would probably tell and said, hey, Aim, talk to this family, walk into this room and start the conversation. I would tell them the same thing that I say to every family. My name is Amy. I work with the doctors and nurses who have been taking care of your loved one. And I support families who've had the kind of conversations that you've had so far. I'm here to walk with you and help you through some of these next steps, but I don't want to lose sight of the person that we're talking about. What would be something important for me to know about your loved one? That contextualizes and feels more authentic to me than tell me about your mom, because it's like, well, why? Who are you? Right? I'm here. I work with these people. This is what I'm going to be doing that ate it in a sense. And I don't want to lose sight of who we're talking about. What would be important for me to know about them? I know that if the person sitting across the table from me goes, what uses the I can automatically know that this person has a strong, close emotional bond with that person, and that they're going to need additional support because they are just already coming apart at the seams, versus the person who says, like, do you want to know what they did for a living? That's a family that's in a different place, and they're processing information differently, and I can cut some of that softer emotional support to meet their need of like, what is it that you want to know, versus the person who bursts into tears and tells me that their mom was just the best. And there's so many things that they could tell me. How could they possibly pick just one? I already know where I'm going in that conversation so that I can use tools like this Spikes model, the ask, tell, ask model, the I like, I wish, I wonder. And then another model that's similar to Spikes in a way, and I bookended this for a reason, which is that nurse model. So these are both Spikes and nurse, both acronyms for guiding a conversation. So looking at the Spikes model, this is choosing a setting, having conversations in the right place at the right time. These are foundational aspects of the work that we do in Family Approach. This model is best used by treating teams. This is not something that tends to be something that OPO people use a lot. In fact, the Spikes model was created in the setting of delivering poor prognoses to patients who are receiving the diagnosis of cancer. And so you can see that the setting and the perception and the knowledge of like disease and care options in plain language, that may be true in the setting of a DCD donor, where these are the limitations and this is how it will affect their ADL, and how and what does that mean for quality of life for your loved one. But truly, in an effective setting, this is something that happens prior to the OPO's arrival, and it is best utilized and most effective when we're delivering bad news in clinical settings. These are things that maybe best case scenario, your ICU practitioner has a very high EQ and is using this tool already. They're pulling family into a little conference room and say, I'm Dr. So-and-so, I'm taking care of your loved one. It sounds to me like you might know that they were involved in a bad motor vehicle accident. accident, can you tell me what somebody has told you so far, what is happening so far? I'd like to tell you a little bit about what I've seen as an ICU doctor, if that'd be okay. And then they can explain that they've had a very bad injury to their brain, or in the accident, they broke a lot of ribs and that caused some bruising on the lungs, and it's hard for them to breathe. So right now I'm worried about how much oxygen is circulating, seeing and responding to how they receive that information, and then saying, I'm going to go back to the ICU and see if that oxygen level is up any, or continue to treat it a little bit. I'll give you an update soon. We all know that that is the wet dream, best case scenario of physician communication in an ICU setting. Since we're not the ones delivering this, this is something, though, that you can influence and say, hey, Dr. So-and-so, you're going to talk to the family. How did they seem when you asked them about what they knew of the injury? And that might be like, oh God, I didn't ask that question. And then what did or didn't happen prior to you walking into that room. So this is a tool that I know which doctors use and have this capacity, so that when I go in to follow them for a family approach, I know what I'm following, and I know the ones that don't. And so I may preempt them to say, how did the family respond when you used invitation and asked them what they would like to know? How did they respond when you asked them what questions they had? And if it's met with that same stony silence, that's a teaching moment for that physician. And it's also a knowledge point for me for when I go into that space. And so I try to do gentle educations, because if they're not receptive to being educated by a core person, it will surely backfire. I think often of that big fat Greek wedding. The man may be the head, but the woman is the neck, and she can turn the head whichever way she wants. And for as many years as I've been doing this, I still find it odd to say, your job in these settings is to be the neck. That's welcome to this world. You got to be the neck and turn the head. But one of the other, so that's the spikes model. What we tend to see, and what is also very effective in an approach setting, is an ask, tell, ask. So what can I'm Amy. I work with families. I support families having the same kind of conversations that you've had. What would be an important thing for me to know about your loved one? That's an ask. They tell me, I can validate that immediately, so that the girl who goes to bits about how amazing her mom is, I can say, how lucky it must be for you to have her as your mom, right? I can also say, it must make what the doctors have told you so far that much more hard to believe. Tell me a little bit about what they've told you so far. Yes, that's right. She had a very large aneurysm. And what that means about where that aneurysm for her is. And then you can kind of fill in the blanks and validate that again with more asks. So this is a very effective model. It's best used in validating their understanding of what communication has been relayed, and then also determining what the next steps are. A classic case where I wish I had known this was when I was early in my career, and the doc said, well, the family's ready for you. And I said, oh, that sounds great. And I walked in, and she was flat affect, and she's like, yeah, I said, so what happens now? She was able to parrot back what brain death was. And she said, well, the skilled nursing facility wouldn't take him with the pneumonia. So I guess we'll just have to figure out if they'll take him with the brain death. I didn't know this, and so I had really approached donation, and she said no to donation, and I was like, well, why? She's like, because I'm waiting to see if he'll go to the SNF with the brain death. Using an ask, tell, ask in that early opening and sort of that footing finding really tends to be the best place for this, so that you know where to take that conversation. That ask, tell, ask will also give you the sense of, if your family is a down to business, no frills, what do I need to know, so that you don't inadvertently frustrate them. If you are, as I am, a soft and mushy at baseline, I can cut the fluff and get right to the brass tacks. An ask, tell, ask model will get me there, so that I don't frustrate my end user. The I like, I wish, I wonder is another very effective modality. This is best used in my experience when there is a difference of opinion or a lot of emotion in a conversation. And sometimes what it looks like is when families are really angry. I have been here all night and I haven't even eaten and da 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 da, and all I've been doing is waiting for a doctor. And nobody can come here, and now all of a sudden you want their organs. Okay, that gives me a chance to step back and I can say, you know what, I really like that you feel comfortable being so honest with me. And I either wish I had known that or I wish our team had done a better job connecting with you. Using silence is another very effective tool in giving pause and giving space. Um, I wonder, knowing how you feel now, if we should take a break and maybe I can see if I can get that doctor to come back and have a different conversation with you so that you can get some of these questions answered. This I like, I wish, I wonder is also very effective in the setting of contested first person, where you have an individual where donation is going to go forward and the family really doesn't want it to, and they tell you you can go kick rocks in bare feet. And you say, you know what, I I really like how honest, and this is usually where I start. Like, I like that you feel comfortable telling me that, and I really wish I had something. I really wish I could give you what you want, which, if I'm hearing you correctly, is that you just want to be done and you don't want them to be an organ donor. And I hear you, and I wish for you that I could give that to you. I wish that this conversation was happening in a different setting, or that you had maybe known this about them prior to this moment in time. I wonder, knowing that donation is going to move forward, what I can do for you in the short term to make this as painless as possible. If you'd like to spend some more time at bedside, let me talk to some of the nurse leaders and see if we can extend your visiting hours. If you'd like for us to be as invisible as possible and not give you updates unless you reach out to me, that's how, I'm happy to meet you wherever you are. I have said to families, I wish I could give you that, and I can't. Outside of that, what does a win look like to you? And it gives you a sense into their headspace, and you might be like, yeah, there's no way I can ever meet that. And then you say again, I wish I could do that for you. I can't. I wonder how you would feel if I, and then offer a counterpoint. So this can be very effective in de-escalating those contentious situations. This was a model, this nurse model was developed with the palliative care team at the University of Pittsburgh. And this is similar to the Spikes model of wherein you're naming, you're understanding, or even the ask, tell, ask, where you're repeating back a little bit. But this can also, again, be very effective in assessing an emotional state and exploring the family's bandwidth. It is something where I have said to families like, oh, you must be exhausted. And the family's like, no, I'm wired. I can't sleep. I can't relax long enough. And I have so much. And then my dad is gonna get cancer surgery tomorrow. And now my kid is here. And I have a dog with diabetes who's half blind. And you're like, okay, you are exhausted, but you're so wired that you're not like exhausted. Now I have a better sense of where you are. And if the family just shuts down and doesn't engage, it again lets you know that kind of which way you're going in terms of their emotional needs. This can also be very effective with rapid onsets from injury to death. So the mother who was just on the phone with her daughter when her daughter lost track of the vehicle, failed to negotiate a turn and rolled over. And the mom was on the phone when the line went dead. I just talked to her. I was just talking to her. This can't be real. This has to feel like a terrible nightmare. Saying those things out loud. Who else would be here? Who else is important for you that's supporting? Who else would be important for you to have here with you? Who do you need to call to tell them? Who loves Jenny the way that you do, that would need to know these things and want to be here with you? So this model can be very effective in that setting as well. Ultimately, and as we close, there are a couple key things for effective communication in crisis. We're trying to decrease that cognitive load for our end user. And what I share with new hires and as I train people is do you want a tuna sandwich? And if you've ever been hungry and someone says like, oh, are you hungry? And you're like, well, I don't know, like not really. I don't know, where are you going? What kind of food do you want? Are you hungry for pizza? Well, I don't know. Which place are you getting the pizza from? All those sorts of things. Instead of saying and giving all of those options, the are you hungry? Do you want to eat? Should I grab you something? Is a very different question than do you want a tuna sandwich? So, as we're approaching and having these conversations, we want to decrease that cognitive load for our end user and have that clear, concise communication at a level that they're ready to receive and process with that feedback. We know that when it comes to organ donation conversations, the leading indicators of whether families will authorize is, do they know the patient's wishes? Do they have enough information to make the decision? Who had that conversation? And then again, when did this happen? So controlling on the front end, those care providers who are going to do brain death testing after rounds and then after journal club at 2 in the afternoon when the accident occurred at 2 in the morning, making sure that the approach and the conversations that teams are having are closely aligned to what that patient and what that family needs. So I'll close there and give a couple moments for questions before the breakout sessions begin. But is there anything that I can answer quickly? I saw my buddy Shantae hop on the line. And Shantae Williams Taylor is the reason that I am still in this field and was more patient with me than I probably ever deserved in my entire life, including many, many, many sleepless nights. And so, Shantae, it's nice to see your name up there. I talk about you often when I teach, and am very indebted to you for the patience and the many good behaviors that you modeled for me in these moments. She used many of these communication tools with me to help validate my understanding. So it's good to see you, my first mentor. It's nice to see your face.
While we're waiting for some questions to pop up in the chat, if you have any, we'll have about 5 minutes for questions here, folks. Just put them in the chat. We'll be happy to have Amy answer them. Amy, one of the things you said early on and you kind of brought back at the end was sometimes someone is just in a mental state where they are having difficulty because their basic needs are not being met. They're hungry, they're tired, they're exhausted, and the cognitive load that's being put on them when they're facing just that need for something small and something simple changes the way that they would make decisions normally. So tell me a little bit about that. How do you, when you diagnose it, like somebody really needs a sandwich or they really just need a little bit of rest before they make a decision, how do you deal with that in your role?
That's a really thoughtful and insightful question. I'm sure everyone has their own way of dealing and addressing this. I've had success saying I can tell that our off-brand graham crackers have worn off. What I'd like is for you to go upstairs and grab a bite to eat before your only option is chicken fingers, and I will come down and I will be here and I will meet you in about an hour. I try to, in those settings, give families something to say no to. Do you want a tuna sandwich? No. Right? So I think our graham crackers have worn off. Go upstairs and get something to eat. No, I'm too tired to move. I don't want to move. Okay, I'll go get you something to eat. What are you allergic to? Otherwise, I'll probably bring you whatever will give you anaphylaxis. Right? So kind of meeting them at that human moment. I've also I had a family that I approached at 7 o'clock in the morning and they were just wobbly all day. And I used shift change as an end point. And I said, well, look, we're getting to the point where the nurses are going to be changing shifts and I am too. And so I need to know how to let the team that's coming on behind me care for your loved one as it relates to donation. Where are you with this? And this was a 40-year-old who had a 20-year life partner who was letting her adult children make the decision, which I was like, come on, be the grown up, be their parent. And so the kids were in their 20s. They were tired. They'd been there all day. The mom couldn't make this decision. And so as it came to shift change, they said, we're not going to donate. And they couldn't look at me. And I said, I don't believe you. I said, well, tell me why. And they're like, we just don't want to. And I said, I don't believe you. And they whipped their heads around. And I said, if you didn't want to donate, you would have told me that at 9:45 this morning. You're tired. So what we're going to do is I'm going to have the nurses take care of him as a donor. Will you get some sleep tonight? And if you change your mind after a hot shower and fresh socks, you come on back here at noon tomorrow. You go home and take care of yourself. And if you change your mind, I will give you this piece of paper. You can shred it, you rip it up right in front of me, and we'll be done and we'll take the tube out. But I don't believe you. And I think you're tired and I think you need to go home. And they signed the paperwork, and our job was place organs. And by noon the next day, from 7 p.m. to noon the next day, we had heart, liver, and both kidneys placed. That family proceeded to the OR for donation. And when the local, like Heinz History Center, did a retrospective on Starzl, they included donor families. And wouldn't you know that the donor family they included was that donor family? And so I think the thing is, donor families put their pants on the same way we do, one leg at a time. And as long as you are leading with compassion and authenticity and respect, people see that. People want to be treated like people. They don't have a lot of agency in a hospital. And so giving them the power to make a simple decision. Do you want this? No. What about this? No. Will this work for you? Okay, we'll do that. Tends to be where I've had a lot of success.
Thanks so much. And we had another question come up, and Jenny, that you put this one in the chat to me. Do you want to elaborate on it?
Sure. I had somebody ping me and they wanted to know a little bit more about the survey that you do afterwards when the process improvement people speak to the approach, the survey the coordinators do after an approach
Sure.
with continuous improvement group.
Yeah, we call this a post-approach assessment tool. And so we have one of our performance excellence engineers reach out and on the phone, they meet with the person who did the approach. And so there's sort of some of those headset questions of how tired are you? Where were you? Da, 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 da. And then, and I'm happy to share it, Jenny. It was actually something that I worked on with an intern. Because she's like, your authorization rate is different than others. What is different and how is it different? And it's like, well, it's how you enter the room and it's all the things that you're thinking about. And it's like, oh God, it's this attending on service. That's why you have to involve your hospital development person, because I'll be able to tell you this guy's a putz. And you're going to have a lot of cleanup in aisle 1. It's going to look like a grocery store after an earthquake instead of the Four Seasons where the pillows are fluffed. Like, you got to use your hospital people who know these docs. And so
Take off.
yeah, so we assess kind of their headspace. What do they know about the family? How did they get the information that they obtained about the family? Did they have time to review the record? Are they looking at OB-GYN notes on 67-year-olds so that they can say, this lady's a P5G5, and the social work note says she has 4 children, and the nurse is telling me that all 4 children are here. Where's that 5? Where's that other kid? What happened to that other kid? Because I was training somebody, they're like, why are you looking at OB-GYN outpatient well lady visits? And I was like, I want to see the number. I hear 4 kids, everybody's here. She has 5, what were they adopted out, died, what happened? And so when you go into that conversation of, I support families who, have had the kind of conversations that you do. I don't know if you've ever been through this before or experienced having a loved one in the ICU with this kind of injury. They said, oh, we lost our brother years back, but it was in a motorcycle accident and he died at the scene. Good. Now I know that you've never done this before. And I know that you are coming into this naive and that this is probably very, very overwhelming. And that you may also be re-traumatized by that because your loved one came in following a stroke while they were driving a vehicle. And so that trauma, that motor vehicle is coming back in. So the tool that we use assesses, what did you know about the person? When did you get the information? How did you review it? How did you use that information? How did you validate and partner with the teams? And my colleague, Alyssa Zahner, who's now in medical school, presented on it at like year 1.5 of employment with CORE. Still very, very proud of her for that work. But I'd be happy to share it. Just send me an email and I'll send it to you.
And speaking of which, thank you so much, Amy. We will be sharing Amy's contact details with everyone when we send our post meeting notes out tomorrow. Amy's also given me permission to send out her slides, which Amy, I love the models that you included in this deck. So useful. And I don't think I've ever seen them all in one place before. So that is just tremendous of you to put that all together for such a brief but impactful presentation. So we really appreciate you being a speaker today and sharing your thoughts and insights with us, as well as some great best practices and tools that folks can take away. And again, we could probably listen to you for another hour, but we're going to move on to our breakout sessions now, just so we can get those in. Guys, it's really important that one of the things we do in this session is we get to know each other. And Amy, were you part of the collaborative way back when, or was that before your time?
Oh, no, I remember the collaboratives. They were
Okay.
the 2005-6 era collaboratives. Yes.
And so many people who are just thought leaders in the OPO world today were part of the collaborative. And I still think I wasn't around for it. I had not joined RPG yet, but I have heard so many stories about it. I think it's one of the best things that OPOs ever did. And it is just fantastic to know that we have so many people that are still carrying on that spirit today of sharing those ideas and best practices. So again, we're so glad to have you. Well, let me just transition really quickly into kind of winding us down here. Amy, thank you so much. So guys, I just want to say on that note to what I was just saying, we are all in this together. And whether you are working in an OPO, as most of you are, or you're someone like me who is working to help serve and partner with OPOs, we're all working together. And the only way that we all succeed is by sharing what we know. And that's part of why these breakout sessions that we have at the end of our summit are so important. And I hope you can stick around, getting to know other people and talking with them about what you're experiencing and what you would like to learn or what you have to share is just as important as hearing from folks like Amy. And so I also wanted to mention that, we at RPG, we're here to help you as well. And we would love to do anything we can to support the awesome mission that you guys are all on. It humbles us, it inspires us. You are our favorite types of clients that we work with, because we work with hospitals and healthcare systems and product companies and all kinds of other things. But what you guys do matters so much, and we're so honored to be a part of it. If we can help you in any way, we can come in and do trainings with your team using knowledge from our research and experience, talking about things like customer service, or talking about things like how to communicate more effectively, or things like that. We have lots of expertise in that area. If you have a problem hospital in your DSA that is really causing you and your organization a lot of grief, let us know. We have a micro study we can do where we can interview up to 10 people, and we can really get to the bottom of what is actually going on. And we use questions that are designed very similarly to some of the tools that Amy was just showing, so that we can really get to the bottom of what the solutions are and not just the problems. And we can help you to turn that around and get donation going strongly in that hospital again. Also, we have a donor family study we do, and we can help you to hear what donor families really, really want. We talk to a lot of them. We usually talk to 125 to 200 of them. We'll include the consent not recovered or authorized not recovered folks. We'll include the tissue donor families. We'll really listen for what it is that they need, both in the hospital and then in aftercare, and come back to your team and help you to prioritize what's most important to them, to know what is working and to know where there's opportunities. And I can tell you, after having done that study so many times, very often communication is the number one issue, either how they're being communicated to about the donation process in the hospital, what they're being promised, or during aftercare. Are they seeing their expectations met? Were their expectations effectively set regarding hearing about the outcome, and maybe even having an opportunity to communicate with the recipient? Setting expectations clearly there is really, really key to making sure that they remain satisfied with the process. So beyond that, we are so glad that you're here. I'm going to split everybody into breakout groups now. And when you're in there, I'd like you to just introduce yourself briefly with your name, your OPO, and your role. And there's this term that I often hear in the OPO world called a pebble in your shoe. And I'd just like to encourage you, if you have a pebble in your shoe, something that's been bothering you or that's been causing you some concern, please go ahead and share that with everyone in the room. Anything that involves interacting with donor families that you'd like to talk about. If it's a boulder in your shoe, that's fine too. Then if you have time, talk about anything else that might be concerning you. And if you have any best practices to share those as well. And I'm going to go ahead and open these rooms now, and we will reconvene here at the end for anybody who would like to kind of close out. We'll just kind of share a couple of quick thoughts, and we will see you in the breakout rooms.